Hi everyone. So I am going to continue my lecture on ophthalmic surgery. So I was on eye surgery and I stopped at enucleation. So I'm going to start on page 610 and it will be about corneal transplants. So I'm going to go ahead and share my screen with you so that you can follow along. So we actually got to watch one of these in class. So if you missed it, it is on my YouTube channel. And I did a lot for eye surgery because I didn't do a lot of eye surgery as a surgical technologist. I was more involved in different specialties and eyes was just not one of them. So I did a lot of eyes as a student to get my experience, but that's all. So it's been almost 7 years since I've been in on eye surgery. So because of that, I put lots of extra resources for you because I don't have a lot of personal stories to go with this. So watch lots of YouTube videos to go along with this. And of course, there's more on Jomi, and you all have access to your Jomi account now. So feel free to watch those videos and learn some more, but I'm gonna get started on page 610. So keratoplasty. So corneal transplant is what they're going to actually call this one. And you can see why we're doing the case. We have some cloudiness and the patient can't see. So that's why you're going to want to understand the surgery, the stuff that they need for it. But on page 610, they really hit the anatomy. So I want you to also study that anatomy. So from the first bullet point, it talks about the sclera and the cornea forming that external tunic of the eye. I want to point out, even on my slideshow, it says that that's a fibrous and transparent structure. So they're fibrous and transparent. That's your hint, basically, that it's in that external tunic. So I wrote that on the slide for you to show you that that part is important. To make sure as you're reading, you're understanding the chambers and the tunics. So this was all what you were taught in anatomy, so that is something you'll have to go review yourself if you don't remember, but I put lots of pictures on here for you, so it might just jog your memory when you see these pictures. And then you can just study what's in your book. But like I said, if you need to, go back to your anatomy book to review. After that, again, read through all of it. You're responsible for what's in your book, but I want you to also focus on what that cornea is allowing the light to do. So your book says the cornea allows the light in the eye and bends the light rays to help the lens focus upon the retina. So it reflects the light. It refracts the light. That's how the cornea is working with the retina. So as you can see, sometimes that cornea is not going to be clear, and we need it clear so that we have good vision. So replacing a cloudy or damaged corneal tissue with healthy donor tissue will correct this vision. So that's what we're doing in this procedure. On page 611, I want you to really look at your equipment, instruments, and supplies. You should already know you're going to need a microscope specific for eye surgery. And then some of these different, like the headrest, the suction, some of these are basic, you should know. I want you to think as you're looking at any procedure in your book, this book, what's different about this procedure? So it's all eye surgery, this chapter. What's special about this procedure? What do I need? What's special is for corneal procedures, you'll need the troughing and the cotting or the Cottingham punch. So that's what's gonna make that big cut in the eye. And as you go through this procedure, it's got pictures step by step. So you'll have a good image of what that's like, and you can also watch YouTube videos. But the troughing or the Cottingham punch is what's different about this surgery, and you need to know that. After that, you'll see practical considerations. So I want to point out these corneal tissues are going to come from a donor. So the eye bank procures that tissue, but they're going to make sure that it is not from somebody who has any diseases that you can acquire. So they're going to make sure they don't have any communicable diseases. So the examples in your book, you should know. So hepatitis, HIV, Creutzfeldt-Jacobs disease. Hopefully you remember learning about that specific disease because that was the one that we cannot kill on our instruments. So if we do surgery on a patient that has Creutzfeldt-Jakob, it all has to get thrown in the trash. Everything that was in the room and even all the instrumentation. So we're definitely not going to take donor organs from people that have Creutzfeldt-Jacobs disease. So make sure you know they are going to test these and screen them for communicable diseases. After that, the procedure. So it goes through it step by step, but this is definitely one that you'll need images for. So I want you to look at page 613. So on 613, they show the trepanation. So that's that trephine that they're putting on the eye at the moment. Then they're going to use that to help place the graft, and then they're going to suture that graft into position. And those are the sutures that you see right here on the picture. So again, if you look at 612, I'm going back, number 4 is the step where they're using that trephine. So that's placed on the cornea and it's used to make the corneal cuts. So we have to make a cut in order to have a place to put in the transplant. So that's what the trephine is doing. I want you to recognize the word trephine and recognize what it's going to do on this specific procedure. And then after that, again, the sutures they're using are going to be 10-0 nylon, so very small, very hard to keep track of. If you are good with very delicate things, then you will be great for eye surgery. So that is your corneal transplant. I want to also point out that it can be what they consider penetrating, but the steps are the same, right? You see the same ring, the teptrine making your cuts, and we're putting our donor corneal transplant in. So still the same steps, just a little different with the images. So if you don't get it from the images in your book, hopefully this one will help you. Okay, then we go on to cataract surgery specific. So cataract extraction. So this one is focusing more on replacing that lens in a different way. So extracapular cataract extraction is what it says in your book on page 614. I want you to read through this anatomy, understand what a cataract is. So know it's used to describe a lens that has become opaque. So that means it's cloudy, they can't see through it. This is not a disease, it's just a condition that's affecting the eye. It's as if the lens has become opacified. So it's opaque and you can't see through it. So because of that, the lens is going to become cloudy, and it's going to receive less light. So blurred vision for the patient is going to distort their view in their images. The development of cataracts are usually due to aging process. So it's a normal process, and you need to know that, and that it's not an abnormal pathology. This is normal aging process. Okay, so as long as you have read over your anatomy on the lens, we can look at page 615, your equipment, instruments, and supplies. So for this one, again, same thing. What's the special thing that's not used in other surgeries that we're using on this specific case? That is your IOL, intraocular lens implant. So you can see a great picture of that here on the page, and then I have one in class for you also to hold in your hand so you can better understand it. But that IOL, the intraocular lens, is our implant for this case. This is going to allow our patient to have good vision again. After that, let's look at your practical considerations. So find where it says extracapular cataract extraction. So that's your second bullet point. So this one is performed through a small incision, and only the lens is going to be removed. So that incision is going to be self-sealing with no sutures required. No sutures required. Then go to the center portion of your practical considerations on the page. I want to talk about handling this IOL because it's very important to handle it the correct way so that we don't damage this lens. So IOLs may be foldable or hard. So foldable lenses are made of silicone. They can be made of acrylic too, but we have them in silicone. Can be rolled up and placed inside a tube that's inserted through a small incision. So here's what I want you to take a note of. It says some of them are foldable. Those are the hard ones. You're going to use the more pliable ones like it talks about using silicone or acrylic. So I want you to make a note. We are never going to fold a lens. Never ever fold a lens. We're going to roll it, as it says a little bit later on. So I don't want you to get that confused because it does say first thing foldable or hard. So I do not want you folding these. These are being rolled only. And that is a good example of a CST question, how to handle the intraocular lens on cataract surgeries. Well, you would gently roll it and place it inside a tube. So we're going to be gentle with this one. No folding, just rolling. Okay, after that, I want to point out that hard, flat plastic version. It talks about that next on that paragraph. It tells you right there that the hard plastic lenses are rarely used and must be inserted through a larger incision. So it can't even be put in the eye in the small incision. The only reason we're able to do that is because we roll it up and stick it through a tube inside the eye. So if you're using the hard flat lens, it's going to be a different procedure, big incision. Okay, and then next thing on your practical considerations, look at phacoemulsification. I want you to know that word and what it is. You're basically irrigating and aspirating inside that eye. So we have many different versions of this in the operating room. We have irrigator aspirators for general surgery, for GYN, even orthopedics, neuro. This is the eye version of that. So phacoemulsification, and the machine is going to just be called the phaco machine. The handpiece, phaco handpiece. So they'll always use that short term for it. So if you're wondering, when are we going to use this phacoemulsification machine? So after the nucleus of the lens is removed, the irrigating aspirating unit is going to remove the remaining pieces of the cortex. So even though it looks like you got it all, you're not always going to get it all on the first shot. So you'll have to use that phaco machine to irrigate and aspirate the rest of that out of the eye so that we can put in our implant. Okay, after that, flip it over to page 616. So on this one, I want to point out that as they're retracting the lid, they're going to use a specific type of suture, and these are traction sutures. It's got a special name for it. So as it goes through the surgical procedure, looking at number 2, that superior rectus muscle, the bridal suture may be used. If you don't understand what bridal suture means, you need to make a note on the side. This is a traction suture. So you can see a picture of that on page 617, plate 16-2. That's where you see that bridal or traction suture. So we are pulling traction to move some tissue out of the way. So make sure you understand what traction suture is, and now you know that term bridal suture for eye-specific cases. Okay. I think I will skip down to number 7 on this page. So you will see that it goes through this procedure step by step with beautiful pictures on the next few pages. So that is why I'm skipping around on this, even though it's a longer procedure. But number 7, I want you to see that vasoelastic. So vasoelastic is injected to reinflate the capsule. That intraocular lens is inserted into that capsule. So some of you got to see this on the YouTube video. If you see some of that viscoelastic coming out, that's okay. If you see some of it coming out of the eye, they're going to inject it into the eye, so some of it will come out, and that's okay. Now they will remove any of that remaining viscoelastic when they're done with the case, but during the case it's fine if you see some of that seeping out of the eye. Okay, and then this one, the surgeon's gonna use a 10-0 or 11-0 suture to do this case. So no dressing required on eye surgeries. We will do surgeon's preference. So I want you now to go through this procedure step by step with the pictures in your book, because it is really going to help you understand the process a lot better. Because I know you're gonna go through it step by step, I wanna stop at page 620. On 620, plate 16-4, it says it again. They can't help themselves. They said the IOL is folded. The IOL is not folded, it is rolled up. So even though they messed up, they used the wrong term, what they mean is rolled. You can even see it's kind of rolled around that forcep. It doesn't have a crease in it, right? That's what I mean when I say you can't fold it. There's going to be no crease in that lens. we're trying to help our patients see, not give them a big line down the center. Okay, so that brings me to my next procedure, actually. So you can see your setup right there if you want to look at how simple this nice setup is. But vitrectomy is my next procedure. So I actually found out that you guys did not get to do your eye dissection in anatomy. So I went ahead and added a picture of your anatomy that you would have seen when you did your sheep eye dissection. So you get to see a really good image of the lens and that vitreous jelly humor in the background. So you can't see it all, but it is a little bit different seeing that sheep's eye in person. So I wanted to share that picture with you. So on the vitrectomy, it really gets into the anatomy. So that's why I added an anatomy picture here for you to show you what to review. But I really want you to separate the cavities, know what the cavities contain. So this first section, of course, we're doing a vitrectomy, so we're talking about the vitreous humor. So it's working on the posterior cavity. So understand where the posterior cavity is and what it contains. So very simply, leaving out lots of details, the posterior cavity is going to contain that vitreous humor, the jelly-like humor. That's going to help maintain the pressure inside the eye. So if you didn't have that in your eye, along with other fluids, your eyeball would collapse. So we have to have that vitreous humor to fill up the eye. That's why if we take some of it out, we have to fill that back up. That's why we have vasoelastic for these cases. Also know your different humors. Like I said, vitreous humor, you should definitely know that. The hyaloid membrane, you should know that that encloses the whole vitreous humor. I think I won't go over any more anatomy, but you can see a nice picture there for you to help you review this information. I would like you to look on the right side top of the page, 621. Know that a vitrectomy is performed to remove the blood so the surgeon can view whether there is a detachment. So that means when we go in to do this case, there's not always a detachment. They cannot see until we have performed this procedure. So I want you to realize that as you are studying through this. That's the actual purpose of the procedure, to remove that blood so the surgeon can view whether there is a detachment or not. Okay, after that, let's look at preoperative diagnostics and tests. So a vitrectomy procedure will be performed in the order for the surgeon to see whether a retinal tear or detachment has occurred. So same thing, we are focusing on that. So if they say it twice in the book, you know it's very important for you to know. So of course, these are for detached retinas. You can look at your equipment, instruments, and supplies. I just want you to look where it says endo illuminator. So light source handpiece cables provided for a fiber optic illumination of the ocular use. So we are basically putting trocars in the eye, and you can watch that on my YouTube channel if you didn't already see it. So we're putting little trocars in the eye to work. That's what it's talking about on the last part of 621. So let's go ahead and flip over to page 622. Now you can see your pictures. So on 622, I want you to see they can use a fragmatome. This is another ultrasonic instrument, kind of like the phaco machine. So this one's going to just aspirate instead of irrigate and aspirate, but it's going to be used to remove that cloudy lens. So it's just another option for the surgeon, fragmatome. They could also use an argon laser to do this. And those are the two I want you to focus on as you study. After that, I want you to also see some medications. So the cryoprobe, that's specific for freezing. Antibiotic ointment, that's on almost every case. What's different that's not on other cases? Acetylcholine with filter. Acetylcholine with a filter. So this one, acetylcholine, you need to make yourself a note if you do not remember this from pharmacology. I understand it if you don't remember it from pharmacology. That's a lot of medications. You need to know acetylcholine is going to constrict the pupils. So the surgeons sometimes need to dilate the pupils and sometimes need to constrict it. On this one, we need to constrict it. So I need you to know acetylcholine is going to help the surgeon do that, or anesthesia provider do that. Well, that brings me right into anesthesia. So pre-op preparation. Look at anesthesia. Very specific, easy to remember. Retrobulbar block is going to be used. So this is actually putting a needle behind the eye. So they're going to go in right here and stick the needle behind the eye and block it from there. So just like we do a nerve block for arm cases, for leg cases, we can nerve block for the eye. Pretty cool. Would not like to have that done to me, but our anesthesia providers know what they are doing. So retrobulbar block is what they're going to get, if not general anesthesia. Okay, practical considerations. It goes through your intraocular gases, and I really want you to read through that. The gas is useful for flattening that detached retina also. It's going to keep it attached while the healing is still occurring in the eye. Now, there are complications of that intraocular gas, and if you go all the way to the bottom, middle section of your procedural considerations, you can see some of those. So possible complications, that gas can progress the cataracts, and it could also elevate the IOP, so intraocular pressure. So they have to watch that very closely while doing these procedures. Next, something different that's only on this procedure is your silicone oil. So the silicone oil is going to help provide long-term support of the retina, and that's only if it's required. But the silicone oil is used instead of the gas to keep the retina attached post-operatively. So this is for after the case, but we will have the silicone oil on our sterile field to use. Okay. After that, go to the very bottom of that section that talked about silicone oil. Like the gas, that silicone oil may promote cataracts and cause glaucoma and damage to the cornea. So that's really hard for these patients. So they need the surgery done, but they know the side effects. So they have to weigh the pros and the cons to decide whether they have to have the surgery done or not. And the surgeon, of course, works with them and counsels them on this. Okay, your next one. Endophotocoagulation. That's endophotocoagulation. So this technique is going to use a laser to treat your intraocular structures. So to treat retinal tears, retinal detachment, and diabetic retinopathy. Those three things. Make sure you know all three of those for endophotocoagulation. So it's just another option. Lots of options on a vitrectomy for a surgeon. They have to weigh the pros and cons and have their preferences of what they like to use. Okay, after that, you can see the next bullet point is on 623. It's lensectomy. So lensectomy is removal of the eye's crystal lens during a vitrectomy procedure. So anytime you do a vitrectomy procedure, you're also doing a lensectomy. So this is always performed in conjunction with the vitrectomy. Make sure you know that. The lensectomy may also be necessary to gain access and to remove any scar tissue. That lensectomy is usually performed in high frequency ultrasound. Okay, I can go ahead and start this procedure then. So it starts with a sclerotomy. So number one on page 623, sclerotomy. There's my supplies. So you can see what it looks like with that silicone oil from this view and some of these supplies that you're going to use on this case. So again, we're going to start with a sclerotomy, so cutting into that sclera. And then our next step will be number two, the sclerotomy. We are going to use those infusion cannulas. So step one, we use the knife. Step two, we insert the cannulas. Hopefully this sounds familiar, a lot like laparoscopic surgery. If you just think basic of what they're actually doing, it's very similar to laparoscopic surgery. So here's where you might want to make yourself a small note. So on this picture, you're looking at a vitrectomy, you're seeing your infusion cannulas being inserted through the sclerotomy. So here's the note I want you to make. There's an opening into the outer tunic. That's what was just done with your sclerotomy, an opening into the outer tunic. So from there, through that sclerotomy is where we're going to insert the cutting, suction, infusion system. So that's all on your picture. So that could be that irrigating system. It could also be that phacoemulsification machine, whatever the surgeon wants to use. But they're going to use it in that opening into the outer tunic, AKA your sclerotomy. So you know sclerotomy, they're cutting into the sclera. What you need to add is that we're making an opening into the outer tunic. And then you can see on your infusion system, you see one side has the syringe and one side has the infusion. So there's a pump actually pumping this throughout the case. Now, because of that, because it's going to be infusing, look at your practical considerations on the top of 624. Top of 624. So the infusion cannula must be primed and the air bubbles must be removed. This is done as soon as possible. As soon as you have this tubing, you want to remove these bubbles, because just like in other surgeries, the bubbles can look like something else. It could also, with this situation, it could cause damage to the eye. So we want to get rid of those bubbles for sure. Okay. I will let you read through the rest of your vitrectomy because you are in and we can see the next steps very easily. So read through the next steps all the way to your 7-0, nice small suture, but not as small as the 10-0 that we used before. It's a little bit smaller suture on this one. Sigh of relief for the script tech. Okay, I knew I had another view of it. So because this one is hard to understand, I have many pictures of it. So if you didn't get it from that view, here's another view for you. So here's how we are putting the trocars, if that's what you want to call them, inside the eye and seeing all the way at the retina. You can also see on these cannulas what's happening inside the eye. So over here on the right where it says vitrectomy instrument, that's that suction irrigator debriding handpiece. You know, it could be that phacoemulsion handpiece, or it could just be some type of suction irrigating device that is going to irrigate that vitreous humor up. So the vitreous is going to be removed with that instrument. Okay, now we are at repair of an eyelid laceration. So this is more common than you think, and many times they think just their eyelid is lacerated, and we go in and we find that the eye has been cut too. So these cases know that they can become more involved. You think you're just doing a eyelid laceration, so you have all these open regular instruments, and then you realize, oh, the eye is hurt. We might have to do some work on the eye, so you might need the eye microscope and all these nice fine micro instruments that you're used to. So communication is key as always. So ask questions so that you can have everything in that room that you need before the patient gets to the room. So repair of a traumatic eyelid laceration or even a regular eyelid laceration. What I want to point out to you are the equipment, instruments, and supplies for this one. It's got some special things. So you'll see that it has a Very's rod. So this is a stainless steel rod that we're going to insert to help fix this eyelid laceration. So you can see that right here on my slide on figure 6. So they're introducing that modified Very's rod into the canaliculus. So if you don't know that term, canaliculus, make sure you know it now, review your anatomy, and read through it. If you can look down on 625 at number 2, the canaliculus is involved many times. If it is involved, we are going to use a Very's rod, as I just said. So letter A, directly underneath that, the Very's rod is placed through the laceration, and the canaliculus is approximated with non-absorbable suture. So we are sewing around that rod and it's going to stay in the eye. The purpose of the Very's rod, it doesn't actually say it word for word in your book, so I'd like you to make yourself a note. So the Very's rod is going to be placed to relieve or prevent obstruction. So to relieve an obstruction or to prevent a further obstruction, you know, because maybe the tissue is inflamed from the laceration happening. So we want to prevent that obstruction. So look up, I skipped a little bit, look up at practical considerations. You'll see exactly what I told you to do, communicate. So confirm with the surgeon if the canaliculus is involved. If it is involved, that very rod will be needed. So it's telling you, again, to communicate so that you have the right stuff in the room for your surgeon. Okay, that's all I have for you, actually. There's nothing left on page 626. It's just telling you your little pearl of wisdom at the end, so I will read that to you. Many pieces of complex equipment are required. Always check the equipment function before the procedure begins. So eye surgery has a lot of specific equipment that you will definitely need to check and make sure it's running well before the procedure. That's not something we can teach you in class. This is one of those things that you learn on the job. So even though you might only do it as a student, just as I did, I learned every bit of it. I soaked it up as a sponge. I remember my week in eye surgery and I learned a lot. And it paid off because even though I didn't get to scrub eye cases, I'm now teaching about it. So every bit of information you can get, just try to soak it up like a sponge, because I promise you it will come around to you later on and you might get to reuse some of that information. So if you have it in your head that I'm not worried about this, I know I want to do L&D, or I know I want to do neurosurgery, you don't know what your job opportunities are going to be. You never know what the situation's going to be. Why not have all your options open? I know the purpose of this college is to get you a career. So I want to help you be a well-rounded scrub tech and really have a career. So I urge you to really focus on the specialties that you're not interested in. So whether you loved or you hated eyes, I hope you invest the same amount of time in it as you do all of the other specialties, and try to keep that with you as you finish out this program. So if you have any questions about eye surgery or any random questions, please send me a Facebook message or an email. I'd be happy to answer your questions. All right, I'll talk to you guys soon. Have a good one.